We will be introducing the panelists here momentarily and all of the speakers, but as is our tradition in Common Spirit Health, Dignity Health, we offer a reflection. So before I even offer the reflection, I should just open up officially by saying thank you so much for attending What's Up Doc, presented by French Hospital Medical Center Foundation. We're very privileged and happy that we can offer educational programming to our community. So thank you all for being here. My name is Tessa Espinoza, and I'm the Vice President and Chief Philanthropy Officer here at French Hospital, and I oversee the foundation. And we do these events about quarterly here, and so we'd love to have you back. And at some point in the presentation, maybe at the end, we have a slide about our next education that's coming up in August, and it's around fall prevention. So we hope that you will join us ongoing, because I think it's a really neat opportunity to hear from experts in the field and ask questions in a meaningful way. So as I mentioned, I kind of bounced around, but we do have a tradition of opening each of our meetings with a reflection. And so I pulled the quote here from Maya Angelou. I know you've probably seen and heard it many times, but I thought that given the focus of tonight's event around mental health, I thought that the quote by Maya Angelou about how we make people feel is relevant. She says, "I've learned that people will forget what you said, people will forget what you did, but people will never forget how you made them feel." And I think that this is really relevant for mental health care as someone who may be in crisis enters our system and enters our ED. They're seeking resources from a variety of organizations. Our approach collectively can be and is around how we make them feel, and whether or not we're fostering hope and dignity for whatever population we're serving. As we will discuss tonight, French Hospital's initiatives, the ED protocols led by Dr. Matt Scales, and countywide efforts and collaborations sort of guide us in how we approach our interactions with everyone and all that we do. And our main focus is to help people feel seen, valued, and genuinely supported. And so with that, I would like to start with our first speaker, who is President and CEO Sue Anderson.
Thanks, Tessa. I'm going to be really brief. Thank you all for coming to hear about this important topic. I know we have a lot of different events on this topic out in the community, but I think tonight's going to be really great for all of you to hear. Not only hearing it from an emergency room perspective, but Jill, who runs our outpatient psychiatric unit in Santa Maria that services all of our hospitals and our emergency room. And so anyway, I think it's going to be just a really good program, and to have the county here too is amazing. I'm looking forward to the talk tonight. So just real quick, a couple of things with French that I just want to make sure our community knows about. First is the Cancer Center that is on the corner of Tank Farm and Broad. That is well on its way. The construction's ongoing there. We hope to be open. We should be completed with construction and everything by the end of December and open sometime in early January. Very excited about that. That project is a multi-million-dollar project, but it will have, from our side, it's going to have imaging, it will have our oncology services, our oncology physicians, it's going to have an infusion center, the Hearst Cancer Resource Center will be in that building, as well as a surgery center, physician offices, general surgeons, urologists, and much more. We'll have some lab in there, imaging. Anyways, it's a very exciting project. We're excited about bringing that to the community. And then we're well down the road. All of our plans are in with the state. We're under state review right now for our tower project here, which is an extension of this hospital, 3-story tower that will put private rooms into our community finally. So more to come on that in the future. But right now I want to introduce Ken Delbout. Ken is our VP of Behavioral Health Services and Operations, and he was instrumental in really getting our outpatient psych unit going in Santa Maria, and that has just been huge for our emergency departments and all, really to get people that are in crisis to somewhere that can really help them. And so very proud of that unit. We've been open almost 3 years now, I think. So almost 4, guy, my how time flies. Yeah. So with that, I'm going to turn it over to Ken.
Yeah. Thank you, Sue. First, I'll introduce our panelists. So first we have Dr. Matt Scales, who's the medical director for our emergency department here at French Hospital Medical Center. Next to him is Jill Austin, who is the director of psychiatric services and neurosciences for Dignity Health here on the Central Coast. And then we have Samantha Parker, who is the division manager for access and crisis services for San Luis Obispo County Behavioral Health. And maybe if we could have, I'm moderating, so I just get to tell them to do whatever I want them to do, and then they share their wisdom and knowledge with you. But first, maybe just brief background of your qualifications. Why are you on this panel? And if you don't know what it is, just make it up. No, Dr. Scales, you want to start us off?
Sure. Thanks, Ken, and thank you everybody for coming. It's nice to see some familiar faces out here and new people from the community. Really appreciate your participation tonight. Yeah, like Ken said, I'm Matt Scales. I'm an emergency physician. I'm board certified with the American Board of Emergency Medicine. I've been here in San Luis Obispo for 10 years, working at French Hospital and Aurora Grande Hospital in the emergency departments. I took over as the medical director here at French 9 years ago as of March, and now I'm currently the chief of the medical staff for French Hospital. So I do quite a bit of, I have a few different hats I wear depending on what the needs are. But as far as the topic today, I have over 20 years of experience in the emergency room, clinical medicine, and over that time, I've seen a pretty significant evolution in the management of crisis behavioral health or psychiatric conditions and how we manage them. The needs have become different. The needs have become more impactful on hospitals, and as different resources in the community shift, hospitals take on more of a burden. So I've seen quite a bit of an increase in the numbers of people we're treating. But also some changes for the better on how we treat people and how we try to maintain dignity with people when they come to the hospital. So that's kind of my qualifications, I think. So yeah, I think Jill.
Do I? Okay.
Yeah, I'll let you.
No, just. Sorry.
I'm waiting for a cue.
Yeah.
My cue. No. I'm here because Ken and Sue asked me to be here. But 4 years ago, I think we started working on, we finally got the go-ahead to open up the crisis stabilization unit in Santa Maria. And I had just relocated to this area, and happenstance all came together, and the job opened up, and it was a great opportunity to try and have some impact or make a difference with regards to behavioral health. My training is nursing. I've spent about 30 plus years in nursing and in healthcare. Some of it's been in neuroscience, stroke, and developing systems of care for stroke systems, but then also working in behavioral health. And so this was a great opportunity to kind of come back. A crisis stabilization unit is a very new thing. It's very new to the Central Coast, and I think it took about a year to get our heads around exactly what do we do and how do we serve this community. And so I think we've gained momentum since then and expanded services to not just Marion, but to the other hospital systems in the Central Coast area. And we'll talk a little bit more about that. But very appreciative to be here today and look forward to the conversation. So.
Hi, Sammy or Samantha Parker, Division Manager with Access and Crisis Services with Behavioral Health Department with the county. And I've been in social work for about 15 years and a county employee for about 12. I started as a social worker in child welfare services doing emergency response. I've overseen adult protective services, in-home supportive services, and then in 2022 I hopped over to the behavioral health department where I was over forensic full service partnership, so wraparound mental health services for folks who are forensically involved. And also over our community action team. At the time, we're 2 licensed psychiatric technicians embedded with 3 of our agencies, law enforcement agencies in the county. In 2024, I was given the opportunity to be division manager over a brand new division called Access and Crisis Services, basically bringing all of our crisis continuum into this one division because it was spread amongst all the others. That was a really big deal for our county. Our community action team, those psych techs, went from 2 to now 5, and a mental health nurse and 2 case managers that are in Paso PD, Atascadero PD, SLO Sheriff, SLO PD, SLO Fire, and we're dipping our toe into AG, PD, and Grover as well. So they do co-response and go out on all those 911 mental health calls, and just been a great opportunity in the last year and a half or so to really expand our crisis services. And we work incredibly close with both hospital systems, basically talking every day and figuring out how to best serve our community and especially those members that are facing behavioral health crises.
Thank you. So the way we'll format this, we have a presentation, but during the presentation, our panel will be asked to comment on certain portions of this. So we've done introductions, we have some background that'll be presented during this PowerPoint presentation. Throughout that, we'll have panel discussion. I have some concluding questions that I have for them, and then we'll open up to Q&A from all of you. So to start, we have seen, as healthcare providers, an increase in the prevalence of behavioral health diagnoses, activities, incidences, especially since 2020. There's all different causes, and there's different reasons for that increase. But I'm going to ask Dr. Scales, why the increase? Is there scientific evidence of where that's coming from, or just what's your observation of why is there an increase in behavioral health incidences or crisis?
Yeah, sure. So there has been a lot of research across the country asking this question. Big institutes, the university health centers, the NIH, things like that, have been looking into what are the reasons for such an increase in these diagnoses and these crises that we're seeing. Multifactorial. There's a lot of reasons for it. COVID-19 was probably the big instigator. Because when that happened, so much of public health resources had to be allocated towards making sure it didn't become a massive calamity. And so some of those resources may have been funneled away from behavioral health. Also, lots of people lost their employment during that phase. Lots of housing issues with people became worse during that time. So financial stress, housing stress, people self-medicate when they have stress if they don't have access to good care. So increase in substance and alcohol use, we've seen all of that since the pandemic, really. I think before the COVID-19 pandemic, there were signs that there were cracks in sort of the system and maybe not enough resources dedicated to behavioral health. And I think that just was the straw that broke the camel's back. So yeah, I think I was looking into this week, just to make sure I wasn't wrong. But yes, it's multifactorial, very much pushed forward because of the pandemic and all of the changes that created with society, all the stressors that created with society. And currently we're still dealing with some of those consequences. We're still seeing housing problems. We're still seeing unemployment or underemployment. We're seeing financial problems. The cost of housing is super high. All of these things lead to creating stress. And when somebody's vulnerable and they don't have access to the right options for care, it's quite easy to fall off, the social network and get into trouble. So yes, we've definitely seen a pretty big increase in numbers of people coming in.
This next slide shows, so these are emergency room visits for Arroyo Grande and French Hospital. So in 2018 to 2019, kind of the baseline, we saw 30 or 40 patients per month that would come in, would be assessed for a behavioral health hold or 5150. 2026, that number is increased to like 60 to 80 consistently. And so that demand that started in 2020, let's say, is still there. Sammy, I was gonna, on this slide, it references mobile crisis response teams, community action teams. Do you want to explain what those are? And how do, those are county programs, right? And how does that relate to the hospitals?
Yeah, definitely. So, is that better?
Yeah.
Great.
The camera can pick up on it.
Perfect. So the mobile crisis response teams, that was a benefit that came from the state of California to counties to create these mobile crisis response teams. It's a 2-person team, and they go out on any call in the community for someone who might be experiencing a behavioral health crisis. They can do what are called 5150 evaluations, so they can determine whether someone is a danger to themselves, a danger to others, or gravely disabled. These mobile crisis teams go out, right, I think we're at about 4.5 responses per day right now. That's an increase from last year from 3.7. But a lot of what they do is try to safety plan. So a lot of their engagement is over an hour of working with someone in the middle of their crisis and trying to safety plan, ultimately trying to avoid that person going to the emergency department if possible, and figuring out resources, natural resources, community resources to put in place so that person's kind of immediate crisis can stabilize and we can get them kind of to the next level of care, whether that's an outpatient visit or what have you. They work with family members if indicated. They'll go to the schools. So if there's a student having a crisis, I believe about 60% right now of the calls do get diverted, which means they're safety planned and not placed on a hold. When someone is placed on that involuntary 5150 hold, they do go to an emergency department for medical clearance. All acute psychiatric hospitals require a certain level of medical clearance or medical information before they're willing to admit, and that's where things get really kind of clogged up with the emergency departments. You might have someone who's in a psychotic episode, found to be gravely disabled, so unable to take care of their food, clothing, shelter, necessary medical care, or personal safety. And that might be next to your son you brought in with a broken leg. So you can imagine that could be a really uncomfortable situation. And then the hospital is doing their due diligence to get that person medically cleared, and then they're waiting for a bed. And so we work really hard on all parts of that kind of continuum to keep someone from the emergency department if possible, stabilize them. Just going on a hold itself can be kind of traumatizing. If you can imagine your personal rights are taken away and you're on an involuntary hold where you're going to be hospitalized for maybe 72 hours, maybe an additional 14 days, what have you. All the way to trying to get them out of the emergency department as quickly as possible. There's only one acute psychiatric hospital facility in our county that is run by our department and is 16 beds for adults only. Later on, we'll get to what's changing. Crestwood is our contractor for that facility. And like I said, 16 beds only for the whole community. And our mandate is to provide those beds to Medi-Cal recipients and folks that are uninsured. So at this time in this county, there are no private beds, which is a huge gap in services. So you can imagine if one of your loved ones goes on a hold and they're privately insured or they have Medicare, they will be sent out of county to a psychiatric hospital facility, and that creates all sorts of other challenges and issues. I've had a family member that happened to, and suddenly they're on their way to LA and you're trying to communicate with an out-of-county hospital that you've never spoken with. So at this time, there is no place locally for folks that are Medicare or privately insured. The community action team is what I spoke of earlier. Those are licensed psychiatric technicians and a mental health nurse embedded with law enforcement. Each law enforcement member they ride with 10 hours a day, 4 days a week, are specially trained in crisis intervention. They go out on all the 911 mental health calls. They do a ton of de-escalation. A huge goal of that program is diverting away from the criminal justice system, so away from jail if you're in a psychiatric crisis and into treatment. Those teams can write holds, so they also visit the emergency departments. We also can get them right into a clinic. We sometimes provide medication out in the field, so antipsychotic long-acting injections with the help of our medical director. And so they're doing an incredible job of also attempting to divert not only from the emergency departments, but from the criminal justice system, where a lot of people with behavioral health needs get really tied up because most of their offenses relate directly back to their behavioral health crisis. They're not actually criminalized human beings.
Do these teams, they'll see anybody, right? They're not limited to Medi-Cal?
Yes.
Okay.
So both the mobile crisis response team and our community action teams, they just go where the need is. It does not matter. They don't say, oh, you're privately insured, good luck to you. While those are both county run, we do not discriminate based on insurance. It's if you're in crises, we're going to do whatever we need to do to ensure safety of everyone involved and stabilization as quickly as possible and get you to the right place.
This slide, the title is called Limited Local Resources. So we're going to go through some of the resources we have locally. Sammy talked about the PUF. I wanted to ask one other question though, and maybe Jill, you can answer this. These crisis response teams, have we seen, well, one is, if you're not Medi-Cal, where do you go for service if you need an inpatient? And then second is, have these teams potentially had an impact on the number of people needing to go to inpatient? And I'm thinking of the last kind of data that we submitted to the county about holds that are coming out of SLO County.
In terms of what we're seeing coming through the EDs from these holds, I think, I think one of the good things and the beneficial things that these teams are doing is that they're trying to safety plan, mitigate, put resources together so these patients don't end up in the ED. So I think the efficacy of and the quality with regards to these teams is certainly having an impact on those patients that are coming into the ED. I think that, when you have a psychiatric crisis out in the field and they come into the emergency room, these teams are responding and they're trying to mitigate prior to coming into the ED, but they get into the ED and, I think you'll talk a little bit more about that, but I think there's a lot going on. It's not just a psychiatric crisis. There could be a co-occurring medical condition that's happening. There could be substances on board. There could be a lot of things that we need to factor in. And so that medical clearance is key in terms of being able to understand really what is driving the psychiatric condition, what's exacerbating it, and how do we get them stable? And can that happen in a 24 to 72 hour period of time? Do they need to be medically treated on the floor before we can do that? Or it's pretty clear cut, they're medically stable and we just need to get them out of county. And so a lot of that decision making happens in the emergency department in conjunction with the hospital social work team as well as the county. And daily, we're talking, there is a huddle, and I'll just jump into that in a little bit. Monday through Friday at 10:45, we meet with the SLO County Behavioral Health Crisis Teams, and we also talk with the emergency department leaders, specifically looking at patients who are in the emergency department. Someone from dispatch is also on that call, and so dispatch is the group contracted with the county to facilitate bed placements and safety planning and coordination of care for county mental health patients. And so that care coordination team is really who's in the ED, what services do they need, how do we get them connected to services, and how do we get things expedited. So that conversation, I think we started that about a year ago, has been essential as far as lining up systems and care coordination and making sure that we try and fill those gaps. If patients can be safety planned and discharged, we make sure that they have appropriate safety plans and appointments following that ED visit. Or at least we're coordinating, hey, that patient was sent to Bakersfield, or they need to get into the PUF. locally here, et cetera. So I think there's been good conversation and good work put together to kind of streamline these systems within the county.
Moving on. So, emergency department. We've heard several times. It's kind of the point of entry. Dr. Scales, do you want to walk us through kind of what happens in the emergency department, and kind of the process that takes place there?
Sure. Can I go back to my last topic real quick?
Yes.
And then remind me, I'll come back to this one.
Okay.
I forgot to mention with the increase in prevalence, we've really seen kind of an outsized increase with adolescents or pediatric patients and the elderly population as compared to prior years. And that's maybe similar causes, but I think with the adolescents and the seniors, the advent and the reliance on technology, social media, and kind of less reliance on physical interaction and social interactions. There's been a lot of studies showing that only interacting with people online does have detrimental effects to behavioral health, especially with the adolescents. So we have seen an increase with the teenagers, even preteens coming in, with depression, suicidality, sometimes psychosis. They're not using drugs. They're just having significant issues, and a lot of it is just social development or lack thereof because of the complexities with technology. Okay, thank you. And then the next one was what happens when people come to the ER. Right. Mm-hmm. Okay, so because of the programs that Sammy just mentioned, many people are kind of diverted from coming into the emergency department in the community. They call 911, they say I'm suicidal, they say I'm in crisis. These teams go to them and are able to help them sort of mitigate and stabilize to the point where they don't have to be hospitalized. But that's not everybody. I don't know what the percentages are. A high percentage still needs more care. They're not safe to be alone. And we need to help them. And so they're brought in either by law enforcement, sometimes family members, sometimes they bring themselves in. They have some insight, like I'm going to hurt myself or I'm going to hurt somebody else. So they check into the emergency department. Currently in San Luis Obispo County, there is no other entry point to the mental health or behavioral health care system other than the emergency department. So Twin Cities, Sierra Vista, French, and Arroyo are where you have to go to get care if you're having a crisis. And what is a crisis? It could be somebody has baseline schizophrenia, they lost their prescription, or they stopped taking their meds, or something changed in their life, or they started using substances, or whatever else is happening. And now they're floridly psychotic, they can't even take care of themselves, walking around the streets. That's one reason for crisis. Other reasons are, stress, loss of a family member, loss of a job, becoming suicidal. If you have a baseline of depression or not, you're suicidal. Some people become homicidal, or they want to hurt other people, and that's another condition. Or they just can't take care of themselves because of these behavioral health issues. So for whatever reason, they end up in the emergency department. Currently, the system in San Luis Obispo County, there are certain people that are licensed to evaluate whether somebody should have their rights taken away and should be placed on an involuntary behavioral health hold, which is a 72-hour period in order to get into a psychiatric facility, see a psychiatrist and psych techs and nurses, maybe get on some medications, get some therapy sessions, and get stable to the point where they're safe to go home. But there are certain people that are qualified and licensed to write those holds. Physicians currently don't have that except for psychiatrists in the county. But law enforcement individuals, so police officers, sheriff, they can do it. These techs, these emergency or crisis workers, social workers, psych techs in the community, and then in the hospital we have social workers that can also evaluate whether somebody meets a criteria for a hold. Lots of legal definitions involved. We don't take it lightly, taking somebody's rights away. We have to assess, or the people that do these assessments, assess a lot of variables to say they are unsafe, we can't get them stabilized, we need to place them on a hold. Okay, so Well, what I do as an emergency physician is I coordinate the assessment from the social worker or the crisis worker. I ask for them to come assess this person to see if they meet criteria for a hold, while at the same time we have to assess them medically and physically. Is there a medical condition contributing to their current condition? Is there a physical problem? Did they have a trauma? They fell and they hit their head. They have a major concussion and it's causing behavioral changes. They're in pain, which is causing them to be aggressive. They're withdrawing from alcohol or drugs, or they're acutely intoxicated with alcohol or drugs. They have other medical conditions like liver failure can cause changes in behavior. Neurological conditions can cause changes in behavior. So we have to take a pretty broad look at people who come in to assess, is this really just a psychiatric issue? Or is there something else going on? We tend to do blood tests on just about everybody because you can't always tell by looking or talking to somebody. We want to check their liver function. Usually we want to check their kidney function. We want to check to see if they're acutely intoxicated with alcohol or drugs. These things help us clue in as to is there something we need to do to try to medically treat them, which will hopefully stop the crisis. And if not, then, and they're put on a hold by the crisis team or the social workers, et cetera, we keep them in the ER until we can get a bed in a psychiatric facility. Like Sammy said, there is one unit in the county. It's the county psychiatric health facility. It's a locked unit. It's for 5150 or other people on hold, and primarily for SenCal, Medi-Cal, or other like jail patients or things like that. Medicare and private insurance generally aren't eligible for that, and so we have to work with facilities like the Marion Hospital outpatient unit or other inpatient psychiatric facilities across California. On a regular basis, out of French ER, we send people to Ventura, Los Angeles, Anaheim, Bakersfield, Santa Rosa, way up north, north of San Francisco, San Jose. Literally every day, we're sending people that far away, 4 or 5 hour drive, away from their family, away from their social support network. But that's what they need. This is the system we have, and they're just in the crisis they're in. They're just they're not safe to go home without further assessment. So a lot of it, as far as the medical care goes, is again assessing for a physical medical cause. We do treat with medications when people are really anxious, agitated, if they're exhibiting psychiatric or psychotic symptoms like hallucinations, or if they're talking, if they're having experiencing situations where they're hallucinating or they're reacting to stimuli that are not currently present, like talking to a person that's not there, those kind of things. We have medications that we offer, and we generally offer it voluntarily. Would you like me to give you some medicine to help you with your symptoms or help you feel more calm? If they get to the point where they're becoming at risk to become violent towards themselves or staff, we tend to have to medicate in order to keep them and staff safe. So we do give intramuscular injections, and rarely we have to restrain people physically. Ever since, I don't know, well, I'll talk about it in another couple slides, but we've gone through a lot of changes at French Hospital with how we assess whether somebody could be physically violent towards staff or themselves right off the bat in order to avoid putting somebody in physical restraints. We don't want to strap somebody down. That's kind of what it is. You put leather straps on people. We don't want to do that. It causes them pain. It causes them potential injury. It causes staff injury. So we've put a lot of effort into reducing that, and over the last 5 to 6 years, our use of restraints has gone way down at French. So it's a lot of things happen when somebody comes to the ER with these issues. A lot of times they're acutely ill from a behavioral health standpoint. They're agitated. They don't want to be there. A lot of times they're not cooperative because somebody's forcing them to be there. So it's a really complex situation. But like I said before, we've done a lot to add, kind of replace dignity into the situation for each individual, trying to avoid putting any hands on people, putting any restraints on people, and using evidence-based practices to make sure we keep them safe.
I want to highlight something that's changed in the last year, using technology and how we have used that to better assess patients in the ED or do it in a more timely manner. I don't know, Jill, can you explain how we use that, or whatever we want to call it, the remote assessment team?
The use of telepsychiatry we're using it on the inpatient unit, but we're also using it in both French and AG. And I think it was July of last year, right? When the county, we had a shift in regards to practice, and so the county transitioned where they were doing evaluations, and so that left French and AG looking at who should be doing these evaluations for patients who come into the ED, and evaluating a patient for 5150 under the roof of the hospital system. And so we don't have social workers 24/7, and so we were able to kind of contract with our system-wide providers to do teleneurology or telepsychiatry 5150 evaluations. And so it's an iPad at the bedside. I'm sure many of you are familiar with telemedicine and what that looks like and feels like, but it's been able to expedite services and care so patients aren't waiting as long. Decision-making can happen sooner versus later as far as being able to do that evaluation with a trained and credentialed provider. And so we're doing that not only in the emergency departments, but we're doing that, we're using that technology in the crisis stabilization unit as well.
Has that, as far as you know, has that increased time for assessment or reduced the time to assessment?
I think it's reduced the time to assessment because we were able to get social workers or the telemedicine provider there sooner versus later. Sometimes if we were waiting for an external service to come in and do that evaluation, you could wait 2 to 4 hours, depending on a day and what their load was looking like. And so this can be expedited within an hour or so. So we're getting to the decision making quicker. Patients are getting serviced a little bit sooner. And so I think it is reducing time with regards to length of stay.
Okay, and don't go very far because the next question is for you too.
Okay. Okay.
So we've talked about the emergency room. Something else that it's Dignity Health has put this in place, but it's benefited the entire county, and that is the outpatient psychiatric unit at Marion. So do you want to describe what happens there, what role, kind of
You bet.
the scope of service that it fills?
You bet. And a couple things. It's called the outpatient psychiatric unit, and that was a licensing condition when the county put it together. It's called the outpatient psych unit. It is a crisis stabilization unit. We're open 24/7. It's staffed by nurses 24/7. And once you enter the unit, it looks and feels like an inpatient psych unit. We have 8 chairs, and I think, do you want to go to the window? Just there's a picture here that will kind of show you what that looks like. An empath unit, which is more the philosophy and kind of the idea of what an empath unit is. It's a space like this, and we have 8 chairs. We have a couple quiet rooms where if it's overstimulating and they need some space or just need to go lay down separately from the rest of the milieu, they can do that. We have consultation rooms, there's a shower, there's laundry services, there's individual bathrooms. So it really provides a space for patients to decompress, to see a psychiatric provider, and I'll get into that in a minute. But I wanted to differentiate what an outpatient psych unit. It's not a clinic. It's a 24/7 inpatient psych unit. It's the only one in the Central Coast area. Again, we've opened in September 4 years ago, and we've seen almost 3,000 patients that have come through the program. Some of those are repeat patients that have come through. The recidivism rate within this population is high, and so sometimes we'll see patients that cycle through. We take clients from Santa Barbara County. We are located in Santa Barbara County, and so Marion, Lompoc. We also have a contract and work very closely with Vandenberg for their servicemen and women in crisis, French AG, Twin, and Sierra Vista. So our network has expanded quite a bit, and we take patients from all of those outlying emergency departments. The goal and the benefit with the crisis stabilization unit is really that the patients can get out of a chaotic emergency room once they're medically stabilized, and Dr. Scales talked a lot about what is entailed with that. But once we identify their primary condition is a psychiatric in nature, it really does need to be evaluated, and they're stable enough to be in this setting, then we'll transfer them to the unit. What's important to know is that it is a locked unit. Patients can't go. We are LPS designated, and so we take patients on a hold as well as voluntary patients. But they see a psychiatrist probably within an hour of being there, and that psychiatrist is primarily looking at what is causing the psychiatric crisis. How do we help? Is this a medication issue? Are you on the right medications? Can we stabilize you in 24 to 72 hours? Can we keep you in this environment? In addition to looking at all the psychosocial factors, is there a homeless situation? Is there drug and alcohol that we need to kind of focus on and differentiate a little bit? When you look at the spectrum of patients, it's not just the homeless, it's not just the chronic. You have patients coming out of, patients and students coming out of Cal Poly who are dealing with, maybe it's their first psychiatric crisis. It's a highly stressful situation, and those who really are preconditioned to psychiatric illness, sometimes that happens first year of college. And so we see students that come from Cal Poly. We also take care of a lot of postpartum patients, and depression is our primary diagnosis. So it's not the chronic schizophrenia. It's not patients who are substance use. Although patients come into the unit, about 60% of those patients do come in with substances on board. So we're taking a look at that as we're kind of differentiating and seeing really what is the plan of care. How can we best treat and manage this patient, and can we do it in a way that keeps them home and in their community, or do they need a longer period of time and we need to send them out? So I think when you look at about 3,000 patients, about 60% of those patients have been able to stay and discharge from the unit. So you're reducing the number of patients who need to be transported out of county. And then the goal is also to get them established to community providers and set up within the systems of care with both the county as well as the privately insured. And so as you've heard, the privately insured seem to be the most underserved in our county. From an acute care setting perspective, there's certainly outpatient providers and resources to lower levels of care for both, commercially and state-funded patients. But one of the things that we try and do when they get to the unit is take a look at who's their support system. Are they housed? Is housing going to be an issue? Do we need to start looking for resources for them? Are they already established with a provider? If not, we get them set up with an outpatient appointment before they leave. What medications are they on? Do they need access to new medications? Are the medications working or not working? And we also try and get patients set up so that, long-acting injections are big within the chronic community. And so have worked closely with the county systems. And mostly it's for the chronic population, right? So they're going to the county systems. And so Santa Barbara County, the clinics on Foster Road, we have great collaboration and communication with that group to make sure that there's great handoff when patients are leaving our unit with regards to medication adjustments or changes, what they need to do going forward, and, all that stuff. Sorry. So I think the unit has... I will say, and I have to shout out to both Ken and Sue and Dignity Health and Common Spirit. They have allowed this unit to be what it needs to be to serve this community. Under licensure, we are a 24-hour unit, so at the 23 hours, we only get paid for 23 hours, and most of our patients are there longer than 23 hours. But they support that. Patients are being taken care of, that the care that they're getting is preventing and hopefully mitigating the need to expend additional resources and services as patients are being transported out of county for care. So, and that is seen, I think, with regards to what is felt on that unit. We don't have security, so we have to consider who goes into that milieu. Not every patient can come out of the emergency department. It's a safe space, it's a quiet space. And so that culture within that unit is really factored in when patients are transferred into that unit, with the intent of creating a healing and supporting and respectable environment. And so I think sometimes that's what's missing in an emergency department. There's so much going on. And I think for those who are already in a psychiatric crisis, for safety measures, things are done and steps are taken to ensure that those patients are safe, that the staff are safe. But sometimes that may not feel respectful in some regards. If it's my daughter that's having a psychiatric crisis and she's suicidal, it's really hard to be put into scrubs and to have all the belongings taken away and to have a security guard outside your door. Hospitals need to do that, but I think we also need to create a different space for everyone to be respected in that process, and that we're really looking at what's going on clinically. And I'm going down a tangent, and I won't do that, but I think it's what this unit has done. I think has been very beneficial for the Central Coast. So, yeah.
The slide that's up points to, I guess I'd say in a broader sense, we can make change that makes a difference. And so if you look at the outpatient psychiatric unit, prior to its opening, we consistently had lengths of stay of 20 to 30 hours for patients in the ED. In an environment, one correction, the doctors are always compassionate in the ED.
For sure.
The physical space might not be the best, but I didn't want Dr. Scales to feel bad about that. So,
No diss on the EDs. It's just.
But we had extremely long lengths of stay, and that length of stay has come down. This is 13 to 18. I actually think it's lower than that for sometimes. But so we can make change that makes a difference.
Can I make a comment?
Yeah.
So just kind of on this topic, I did mention all the facilities that we have to transfer people to: Santa Rosa, Bakersfield, Ventura, Anaheim, San Diego, But since the OPU opened, the numbers of those patients has probably been cut in half, I would say, and that's just an estimate. Hence, we're waiting less time in an emergency department, which is not the right environment for these people going through a crisis. I'm sure you've all been in the ER. It's chaos. It's organized chaos, but there's a lot of sounds. There's a lot of people running around, things you don't want to see if you're in a crisis. So staying longer there isn't helping, and so the goal is to shorten that time. And since the OPU opened, you can see here, these numbers may even be better now. This is probably old data, cutting it close to in half. And that sounds like a long time, 13 hours. It is a long time to be in an emergency room, but that's pretty good for these types of patients who need to be transferred long distances.
Yeah.
So it's been a huge success. And you heard Jill, 60% or more of the people that go there are able to be stabilized and go home within a day or two and not have to go to these far-flung communities that they don't know. We consider Santa Maria, part of basically SLO County. It's right across the river, so they say, and it's really very helpful to have that partnership.
So I want to talk a little more. So what other changes have we made? So Dr. Scales, the emergency department at French has made some changes. You want to go through those?
Yeah, so fortunately, the French emergency department went through a expansion and renovation project in I think we opened in March 2020, just in time for the pandemic. That just was really lucky. But part of that redesign, we were able to add 2 dedicated rooms that were specifically designed for the behavioral health patients. So what modifications are there? There are specific pieces of equipment that are designed so that somebody who wants to hurt themselves can't tie something around it or choke themselves, those kind of things. We call it ligature-free zone. We have it's in a quieter corridor of our ER. It's not in the main hubbub where the ambulances are coming in and stuff. So it's in a quieter corridor. People can rest while they're waiting. We do have either a clinical staff member or a security member in that corridor to just monitor and make sure nobody is escalating or at risk of harming themselves. So the redesign was really helpful for this population. We have you can see the list here. There's dedicated staff. Like Jill mentioned, we just started using telepsychiatry about a year ago or less. And it does help. Sometimes a psychiatrist on the line can give us some recommendations on starting medication or other treatments while they're waiting to go to a facility. So we can actually get ahead of the game. They're not just sitting in the department kind of spiraling and not getting any help. We can have a psychiatrist help us with a consultation and advise on some medications while they're waiting. They also have been able to get in front of the patient in a much quicker manner than previously. These patients in the past were taking days to see a psychiatrist, and now with the OPU and the telepsychiatry, they're actually getting in front of a psychiatrist within a few hours usually, which is pretty helpful. And then we're working on getting licensed psych technicians. These are specially trained people that know how to communicate with people in crisis. They know how to de-escalate people and just help them, kind of just be distracted from what's going on, play games with them, those kind of things. But also to intervene in situations that might be spiraling out of control. A licensed psych technician is better trained than an ER nurse or ER doctor or whatever. They have specific tools that they can bring to that. So those are some of the things the department is doing as a whole. We've also, the clinical staff, the doctors and nurses, even like registration techs and EMTs in the department, a few years back went through a emergency psychiatric intervention program. So what is that? So over the past 5 to 10 years, there's been a pretty big shift in how we take care of people in the emergency department that have these issues. We used to kind of put them in a locked room, lights off, and just they're just on their own, check on them every once in a while. But that doesn't work. It's not helpful. It makes things worse. And so with evidence and research, there's some best practices. And some of these are making sure we assess these people early on about what is their risk of harming themselves, what is their risk of harming other people. If we determine that they have a pretty high risk, the recommendation is to start them on medications right away. And it could be an antipsychotic medication, it could be an anxiety medication, it could be a sedative medication. There's some gray zones when you think about that, but honestly, it helps people get out of their crisis faster and without harming themselves or other people. So the recommendation is to offer them a pill. I see you're anxious, I see you're stressed out. There's something I can give you that it's just gonna kind of mellow you out, help you while we wait for the next step. We also use this clinical tool called the BARS score, which is a 7-point score that assesses the level of agitation somebody might have. And agitation is a clinical term meaning hyperactivity and then on a continuum towards violent behavior. 1 through 7, basically 6 and 7 is bad. And we want to intervene when they're at like a 3 or 4. So when they first come in the door, if they're in the 3 or 4 zone or even 5, we know we need to get some medications on board before they escalate. That's a new thing too. In the past, we would just walk away. Oh, you're upset, I'm going to walk away. And then they just spiral to the point where they're really upset. Now we offer them medications when they're somewhat cooperative. They take the medications and we avoid these violent encounters. De-escalation training. So I mentioned the psych techs. They have tons of training on that, and social workers do too. Myself, when I went through 11 years of schooling and training, I didn't get de-escalation training. I got a lot of communication training and how to talk to people, but I never got de-escalation training. But we all went through a program here to learn ways to, even just the way you stand when you talk to somebody who's agitated, where you stand in the room, how your voice is toned, offering to back away, offering to let somebody be alone for a little bit. There's all these techniques that can be used for de-escalation. So we've all went through that. And then when you combine all those things with the physical rooms, the staff, the de-escalation, the EPI, which is the Emergency Psych Intervention Program, we have seen a decrease in our physical restraint use and intramuscular medication use, although we still need it on occasion. So, and then, collaborating with the county, we have a quarterly, I think it is, Sue. We have a quarterly community collaboration meeting between the hospitals, including Sierra Vista Twin, French, and Arroyo. So hospital leadership, like myself and other hospital administration leadership, sheriff representatives, other law enforcement like San Luis Obispo Police Department, the county behavioral health team, probably others that I'm forgetting, social workers. We've been coming together quarterly for the past several years to sort of talk about issues that are coming up, trends that we're seeing. Are the programs that are being implemented working? Are there ways we can change them? We also can troubleshoot if there's like a particular case that is troubling to us. We can talk about what happened, sort of debrief those things. So that's another thing that's been beyond just the hospital. There's been a lot of effort and resources put into these particular issues over the past few years.
For example, those collaboration meetings, Jill and Sammy talked about a 10:45 daily call. That came up, and one of those is we need a more immediate way of communicating. And it's like, well, why don't we have a call? And within a week, we were on this call with everybody contributed. So it is possible to make small changes that make a big difference sometimes. The county is going to make some big changes, some big impacts. So Sam, you want to tell us what the county has in store over the next couple of years?
Yeah. I'll start with the top. What we have existing is a sobering center on our campus right here at 2180 Johnson, and that's a collaboration between Good Samaritan and SenCal, and they're on our property, 12-bed, 24/7, kind of a place to sober up, if you will. Typically 23 hours up to 72. A lot of it is helping divert individuals away from jail. Police can do drop-off. So if somebody, instead of taking them to the drunk tank or to jail, they can choose to maybe cite them, give them a ticket or whatever they want to do, but take them to the sobering center where they'll have a recovery coach. They've got medical staff, a really great team there. And we're looking to make that even a bit more co-occurring. So introducing more services for folks that are also experiencing not just the substance use side of a behavioral health crisis, but the mental health side. So that's been really successful. We've been seeing it at capacity. Good Samaritan, Terry's in the house here, shout out to her. She collaborates with Cal Poly, St. Fratty's Day. They set up little sobering tents and can even bring some of those students to the sobering center. So just a safe place to sober up, to not be out causing havoc in the streets and not going to jail, but rather maybe being introduced to the concept of recovery and different coping skills. In the last year, I believe, we got $21.9 million grant through the state, through the Behavioral Health Continuum Infrastructure Program expansion. We're really excited about that. In Paso Robles, we have a site that's nearby social services and other important services that will have another 12-bed adult acute psychiatric facility, and for the first time in decades, 4 youth beds for acute psychiatric care. We haven't had a youth acute psychiatric hospital in a very, very long time. So all youth right now go out of county, which as a mom, I think is terrifying to learn that your child is being sent to Santa Rosa or wherever on a 55, 85 is what they're called for youth. And then in addition, we're adding 8 adult crisis residential beds and 2 to 4 youth, depending on funding. those are step-down beds. So right now, if you come over to our PUF, our 16-bed PUF, and maybe you're unhoused and you've been staying at Prado, very likely your discharge plan after 72 hours is going to be back to Prado. And that's really hard to throw a wrench in somebody's cycle when we're placing them right back into the environment once they came. And so this crisis residential is 30, 60, up to 90 days. So once someone is through their involuntary treatment, they can go to a voluntary crisis residential bed. And that's going to give our community partners a lot more opportunity to engage with these individuals, offer services, figure out housing possibilities, get them more maintained on their medication, get those long-acting antipsychotic injections more present in their blood system. And so I'm really excited about that because right now we don't have any step downs. And so we do see, I think Jill pointed out, a lot of recidivism, a lot of people that will go into crisis time and time again. And then currently at our campus right here at 2180 Johnson, we are overhauling what used to be the county crisis stabilization unit, and in partnership with social services, we're going to have 4 beds pretty quickly here, I think by the end of this year, as crisis residential for youth. A lot of it's going to be for foster youth. So Dr. Scales mentioned an increase in seeing youth. We definitely struggle with youth that have pretty severe psychiatric conditions and are in the foster care system. They've had a ton of trauma, they've blown out of their placement, and they unfortunately spend a lot of time in emergency departments. They're very hard to find beds statewide for youth, especially in certain age ranges, those younger age ranges. We can't even really contract with hospitals that will accept youth under the age of 12. Those are really rare. And so this is in partnership with social services, had some treatment money, we had the building, and so I'm really excited to see that launched, I hope this fall. They're actively hammering and knocking down walls and making that another space for kind of from the ED into a step down.
So we all wish that there was unlimited resources to address even more of these issues, but there's not. There's some limitation. But we'd now love to hear from each panelist. What can be done in the next 1 to 3 years? Like, if you could accomplish something in the next couple of years, what would it be? What's the next thing on the agenda? Oops. We'll go back to this slide. So you guys can pick whatever order you want to, alphabetical.
Probably the same page.
I mean, I think from my lens and my perspective, one of the things that I think is significant is access to care, right? I mean, there are no community-based crisis areas when you're having a psychiatric crisis to go and seek care other than the emergency room. And so, you know, there is the concept, and there's big systems that do this where they have a dedicated psychiatric emergency room adjacent to the hospital system. So it's not on a separate campus, it's right there, it's co-occurring, it's co-located, because many of the patients coming in do have co-occurring medical and psychiatric needs. But one of the things that we do know is that the sooner you treat someone who is in AFib or having a heart attack or in a psychiatric crisis, the sooner you can mitigate that, and it's better for the client, it's better for the situation at large. So a lot of times these, you know, even though the system has improved itself and we're having greater access to care, psychiatric patients who come in completely psychotic are not necessarily getting treated for that psychosis, which is an inflammatory process of the brain. It's a medical condition, right? And it's demonstrating itself in behaviors that are not conducive in many social situations. And there lies the conflict we have a little bit. And so better access, earlier access to treatment and care for patients in acute psychiatric crises, I think would be something I would love to see. The CSU can do so much, but it's not adjacent to the emergency department. Sometimes it's just a med refill, and patients don't have a place to go fill their medication, and so they go a week without. Next thing you know, they're back in the ED, and they now need an inpatient stay, or it's it's exacerbated to the point where maybe it didn't need to be if we had better access to some of these things. And really for these patients, the only place to go get a med refill is the emergency department. So my wish would be we had an area of the emergency departments that were housed with psychiatrists 24/7, co-occurring, co-located, where patients would have access to emergency psychiatric care.
I concur. I would like that. I would like a behavioral health urgent care as well. And so it may be not as acute as the psychiatric emergency department that I think also would be super beneficial. But for more of those lower level medication refills, stabilization, police drop off, that kind of location would be really beneficial. I also think we need more just mental health housing. Right now, through Transitions Mental Health Association, we have 2 houses. They're called Adult Transitional Program. They're 12 beds. They're in 2 beautiful homes in downtown San Luis Obispo. They're staffed 24/7. And they do an incredible job of helping people who would maybe come out of the crisis residential program and learn about how to do activities of daily living, they teach them, okay, you're gonna cook for the whole house, we're gonna take you grocery shopping, we're gonna get you set up at growing grounds so you can get back into the employment field. And we're gonna also make sure you're taking your medications, you're getting to your appointments at the clinics. Those are typically 12 to 18 month programs, and they're hugely successful. I've seen it with clients that I've treated myself, but we have 2 of them, and I would like many, many more.
Top that.
All of that would be great. A psych urgent care, psych ED, more housing, like pie in the sky. Let's go for it, right? Like I think we can eventually get there. We just have to keep ringing the bells for the people that call the shots. And I think it's happening. You got a big grant for new kind of acute care facilities, but who knows? In 3 to 5 years, maybe we can move the needle even more than we already have. I think one thing that might be achievable, not that those aren't, because I think in time they should be achievable. We should have, that's like best practice. We should have those things here, and I hope we do someday. But in like a year, I think we can have embedded in the ER psych techs, licensed psych techs, maybe not 24/7. We've been trying to get it off the ground at French for a couple years, and it's been difficult, like fits and starts. We had somebody hired, and then they decided to take another job. It's just, there's not a lot of them out there. So I think maybe tapping into some resources with schools or community colleges that have those programs, and trying to make relationships, offering programs here, and working with the hospitals and other resources to get that prioritized, because I think that would help a lot with this population in our ERs. And then the longer term stuff would be really good too.
We'll take some questions from the audience, but one last question. The event's called What's Up, Doc? So I think Dr. Scales needs to answer the last question. So what can an individual do or don't do to avoid being in mental health crisis?
Well, I think a lot of it goes back to just basic wellness and just self-care, although that's not always enough. But everybody in this room, all your family members, this is time immemorial, like forever. If you have a good diet, like healthy, well-balanced diet, you limit or moderate substances that can create problems, tobacco, alcohol, all the drugs. You have good sleep hygiene, go to bed at the same time every night, try to get 8 hours of sleep, get up at the same time in the morning, physically active. That's going to help everything in your health. It's going to help your mental health, your mood, your relationships, physical health, everything. So that's number one. But other than that, I think it's really challenging, but avoiding substances is probably the top priority. with people who have either already been diagnosed with psychiatric illness or are at risk, family history. If you have a family history of schizophrenia, depression, there's a much higher chance that you as an individual will end up experiencing symptoms of that. The chances are much higher if you start, using substances. Unfortunately, substances are used for self-medication because they help people feel better. So it's really difficult, but I think that's probably the biggest thing that people can do. Now, is that realistic? I don't know. It doesn't seem to be very realistic because it's a really big problem. Following up with care plans that are set forth by primary care, psychiatry, social workers, nurses, and following through on those care plans instead of just saying, I feel better now, and so I'm going to stop taking my medications. That's helpful, although it's also difficult. And then I think just being consistent with whatever treatment plans that have been outlined. I think the majority of people we see in acute crisis at the ER level, there's probably a few different cohorts, but one would be people who have chronic illness that stop taking their medication, whether they lost access to medication, they couldn't get their prescription filled because they lost their doctor, or they lost their prescription. So it's not really their fault, but they stop taking their medications and then their symptoms flare up and they end up in the ER. Number two would be escalating with alcohol and drugs. Methamphetamine is probably the number one contributor to acute behavioral health crisis when you talk about substances. And so that's also a big one. But I think it's challenging. Individuals with these illnesses, and I think probably everybody in the room has a family member, a friend, or something that you've dealt with these issues. I personally have family members who have these issues. It's really challenging for them as individuals to follow through with these care plans because some of the medications have side effects. They make you gain weight. They have risk for diabetes. They take energy away. It's libido issues. It's the list goes on and on and on. So it's difficult, but I think it goes back to taking care of yourself with those basics, and then call for help. Phone a friend, call your buddy, call your doctor, call 911. There's crisis hotlines you can call if you get to that point.
I have time for a couple of questions. Jill.
I was curious about how much philanthropic support you get for your behavioral programs.
Is a great question.
No, we've gotten a lot because when we first built it, it was all off foundation donations, approaching $2 million that allowed us to do it in the first place, and then we continued to get some grants.
Yeah, there was a SEDCAL grant that was $2.2 million, and then they added on some. So you had that to start the grant manager. So you said start at the
And community donations, the ag community gave a lot of money for it.
Yeah.
We couldn't have done it without community support.
I have one question for Samantha. The homes that are being built on Bishop Street, what kind of behavioral health help are they getting? Is that the focus of the housing?
Those are all through the Department of Social Services and part of the Bob Jones Trail relocation. However, because where they're situated, that's going to be huge. They can walk across the street and do a drug and alcohol services walk-in. They can use the sobering center. So we're going to be collaborating closely with them. I love the tiny home model. A lot of our very acute clients, when I worked with the Forensic Full Service Partnership, would go to the 5 Cities Homeless Coalition little cabins, and having those 4 walls to yourself and not being in a congregate setting was really important for somebody who was starting on an antipsychotic medication, was considering their relationship to substances. So I think that model mixed with our health campus right there is going to be really successful. And so we're very excited.
Yeah, I guess when you talk about individual care for yourself, I work in the public library system, so we see our fair share of people who are experiencing homeless issues or drug and alcohol issues or mental health issues. And I guess what I'm kind of thinking is, how do we work as a community? I mean, we have now a social worker based at San Luis Obispo Library full-time. He's supervised by social service, by somebody there. And we have 14 libraries. What about other organizations, or I guess just thinking more of a community approach to identifying, to supporting people?
That's a good question. I mean, you probably know most about, or both of you, more than I do about those services.
I just think we're really blessed in this community with the size of San Luis Obispo County and just the collaboration you heard about today. That extends to, I was at probation earlier with like 6 different law enforcement agencies all talking about behavioral health and the community action teams. And so I think it's happening, and I think we're just in this unique position. We're often the pilot county for really interesting innovations. At social services, we were often the pilot county for child welfare programs that were innovative. We were one of 2 counties to implement SB 43, the expansion of grave disability, before the rest of the state did it this year. We implemented it in 2024 along with San Francisco. And a lot of that was because of how collaborative we are with our law enforcement, with our hospitals, with our social service teams, and our community. So I think it's happening. I think it's important that we just do more of that co-location. So years ago, law enforcement wouldn't really imagine riding alongside someone from behavioral health, but our worlds have converged, just like our worlds here have converged. We're all in it together. And I think this community is very strong because even with the jail, we've got Dr. Stefanski over here, we meet with the jail regularly. We're all in it together, and we're all trying to support our community members as a team. So I think just continuing that collaboration.
Just on speaking of the early onset of your presentation of the senior dynamic and not having the resources if they're Medicare, what can we do preventatively to really look at that mental health early on, as many of us have parents or grandparents that are aging, so that we don't get to the part where they would have to relocate? What can we do, or know what resources for seniors?
I mean, I think we've had many seniors that have come through the program, and one of the primary contributing factors to their emotional state is loneliness, right? And so there's a lot of loss, and there's a lot of physical and emotional changes that happen. And I think, one of the things that we've tried to do is get them really connected to services. The aging services, Silver Sneakers. There's a lot of community-based support programs that the county has that really, if you can identify that for them and then really talk about how do you start to engage and what resources do you have and how do we reconnect a little bit, and just reframe that a little. Sometimes transportation is, that's your access point, and so really looking at how do we set them up so that they have access to that information. Yeah.
One more question about Danish. They have converted to some psychiatric beds. So could you tell us a little more about that?
Yeah, Generations Healthcare, they took over the old Danish Care Center in Atascadero, and it's now called Coastal Oaks, and we've contracted with them. We're really excited. Don't quote me on the bed number, but I believe that they have 30 skilled nursing beds and then 30 specialty treatment program beds, and that is a locked skilled nursing facility with a behavioral health component. And so we've actually been able to bring back some of our conserved individuals, conservatees. That's another gap in our services here is we don't have a lot of like Institute for Mental Disease beds. Those are locked facilities or locked skilled nursing facilities. So anyone on conservatorship is usually sent out of county initially, and we've actually brought back quite a few people to be at that Coastal Oaks facility. We're really excited about it. It's just been in the last few months that we're working with them. I toured it. It's beautiful. They have enrichment area, basketball court, outside area, and so that is more for our folks that are conserved due to their behavioral health condition, and the hope is that we would get enough care and stabilization there to then step them down off conservatorship. But yeah, new and exciting.
Yeah, one more question.
Yeah, how would the county use the funds from the Behavioral Health Services Act?
Oh. Really? That's the last question? That's not my division, but yeah, so a lot of all of our funding really was the Mental Health Services Act, and then Proposition 1 passed, and that's transitioned to the Behavioral Health Services Act. So right now we're just in a huge transition. I have a counterpart, Dr. Rajlal, who's overseeing that transition. We're bringing a ton of evidence-based practices. So ACT, assertive community treatment, forensic assertive community treatment, all sorts of acronyms that I can't remember right now. But it has completely transformed our funding buckets, and we're getting more into the housing game. And so much more to come. We're in the middle of proposing to the state what our plan is going to look like. So more to come on that. Very good question.
And the plan's on the website, the behavioral health.
Perfect, on our county website. Yes, okay, there's a plan on the county website with more. It's huge, and it's kind of turned us around, but we're working through it, and hopefully it's gonna just bring improvements. Big lift.
Last question.
I noticed when you, pardon my laryngitis, but when you, each of you projected what would be a great thing to happen in the future, you shot kind of low. No talking about why are we sending people 200 miles to an inpatient facility? Why doesn't a county with 300,000 residents, a middle-class county, have one? I actually have a lot of experience that will tell you the answer to that question, but do any of you agree with that?
Oh yeah, every day.
Inpatient,
Yeah.
So yeah, I think we should have added that to the list. Maybe we glossed over.
We
but
forgot about that.
Yeah. Number 1A, let's get a psych unit that has enough beds for our community.
Yeah.
Period.
Regardless of
Whether it's at a
Yeah, all
hospital or
members of the
whether it's a separate facility that's a standalone, that would be what we need.
So I can give you a little bit, and so, you know, a group from Texas got a grant from the Prop 1 of $25 million as a start to build a 90-bed facility in Santa Maria. And they needed earnest money from the community or somewhere to match in there, and they couldn't even raise it. So that grant went away. And of course, prior to that, it was the village, Harv and Melanie, who have owned a lot and have designed ready to build a facility and have nobody to finance it or run it. And it's very frustrating because it solved a lot of our problems.
I can comment a little bit of that, and then we'll wrap up. Just my analysis of behavioral health right now. It is in huge demand, right? There's a lot of need. The financing of that care has not yet kicked in. And so the demand is great, and the resources, the revenue for operations has not matched what it needs to be. And so it's hard to develop a business. In terms of bringing a facility here to the Central Coast, there are companies that are looking at it. We definitely have the demand and need. The problem, going back to demand high, financing low, it is very expensive to build in California. When we talk about what could happen in the next 1 to 3 years, building an inpatient facility, that's not a 3-year project. But we continue, and I say we, Dignity Health continues to look at different ways to get that done. But it is a low margin business that has to have all the stars aligned to make it happen, and we're trying to align those stars. So just in conclusion, I want to thank the panelists. I can say all three of these individuals have their feet squarely on the ground and their hands super dirty in terms of making things happen for this population, our population that has mental health disease. And so I don't know if it's appropriate to, but can we give them a I'm going to turn it back over to.
Well, you beat me to it. I was just about to say, let's give our presenters, including Ken, a round of applause for moderating the discussion. And I have no doubt that this could have been like 3 or 4 times the length, and because there's obviously a lot to cover, and your expertise and your collaboration is so appreciated and very insightful. So thank you. And thank you all for attending, for your thoughtful questions. And as promised, I wanted to share the information about the next educational event. It's called Staying Vertical, a Fall Prevention Initiative, featuring a documentary. So we've partnered with the Saving Claire Project. We'll air that video and then have a panel of experts to discuss strategies and implementation of safety and safe practices around staying upright and preventing falls in and around where you live and work. So thank you again to all of the participants and presenters and moderators. Don't leave, we have gifts for you. So thank you so much for your time.